Telford and Wrekin Council have written a number of letters. We are finalising replies to the last 2 letters that we have received from them. We've already responded to some of their concerns. It's too early to say yet whether the responses we send back will satisfy their concerns, but clearly as an important stakeholder partner we would wish to have ongoing dialogue with them, both before public consultation and during the public consultation period. The clinical model for Future Fit had 3 components to it. It had the emergency and urgent care component, it had the planned care elective surgery component, and it had long-term conditions. All of those elements are still valid. It is absolutely clear when you look at the evidence base from other places around the country that when you start to centralise services into one place, the outcomes that patients receive are better, the clinical outcomes. So less patients die, and those patients who survive have shorter long-term disability. The IIA is a very comprehensive document, looks at particularly those key groups where there is potential disadvantage of any service reconfiguration. So for example, disabled populations, black and ethnic minority populations, etc. It clearly has indicated that this is a complex health economy where some people in any group could be advantaged and other people disadvantaged depending on where you locate services. But it has gone through that in a comprehensive way, and it's concluded that whilst there are some people who will be disadvantaged, the vast majority would see improvements. So we need to be really clear that just by having to co-locate emergency service for women and children's services, that doesn't mean that all of the services currently provided in Telford and Wrekin for women and children would move. So there are a range of services that you would still continue to deliver locally. That would include, for example, a midwifery-led birth unit. It would include things like paediatric outpatients. It would include diagnostic tests, so for example, blood tests, x-rays, etc. It would include children still going to the urgent care centre for most of their emergency and urgent care needs. It would only be those blue light cases that needed to go to the new emergency centre. And it may well include paediatric oncology, because I know that the Trust are currently holding discussions around whether it would be possible to deliver that in Telford. So if you looked at the range of services that are currently delivered for women and children, the vast majority of those would still stay and be delivered locally. There are a range of services that are currently delivered for women and children out of the Women and Children's Centre. Even if you move emergency care, that means there are still a range of other services that would be delivered locally for women and children. That would include, for example, a midwifery-led unit. It would include, for example, paediatric outpatients, children's outpatients. It would include diagnostic testing, so things like blood tests, x-rays, etc., being delivered locally. It would include things like therapy services being delivered locally. It would include those children who don't need a blue light ambulance continuing to go to the urgent care centre for most of their local urgent care needs, and there would be a dedicated children's area within there so that it's child friendly, which is incredibly important for children to reduce anxiety. And I know that the Trust at the moment are looking at whether it would be possible to deliver children's cancer services locally in Telford. Now, I think it's quite clear, if you look at the demography of Shropshire as a whole, including Telford and Wrekin, the bulk of mums-to-be and children on a proportionate basis live within the Telford and Wrekin catchment area. Nothing has changed about that. However, if the emergency centre is at Shrewsbury, then you have to co-locate the emergency service for women and children's in the same place. But, as I said, the bulk of service delivery for women and children in terms of the care they received would still be delivered in Telford and Wrekin. It would be that small proportion of blue light cases. Now, I would estimate that roughly 80% of current activity in the Women and Children's Centre would continue to be delivered locally. The way you design healthcare buildings these days is flexibly, so that we all know that the way healthcare is delivered changes at a fairly rapid pace, particularly these days of increasing technology. It's absolutely clear that that is a fantastic facility, but it is very adaptable to be used for other services. And part of these changes, the proposal would be to use those for other services. It's too early to say exactly what that would be yet, but that is about the best building stock we have in the county in terms of acute hospital healthcare. We would not want to lose that. The underlying principle we followed all the way through the Future Fit programme was that we were using as our moral compass, how do you get the maximum benefit for the greatest number? Now, Shrewsbury and Telford Hospitals NHS Trust serve a wide catchment area, including all of Shropshire, Telford and Wrekin, but also including parts of Mid Powys. Now, clearly, we have to take that into account because those patients from Mid Powys have traditionally used Shrewsbury and Telford hospitals for their healthcare, and therefore it is a factor that needs to be borne in mind. Urgent care centres will deliver the vast majority of care that currently goes through the two A&E departments. So, for example, things like minor illnesses, for example, slips and trips, for example, lots of sports injuries. The cases that won't go to the urgent care centre are 999 blue light life-threatening emergencies. We believe, on balance, that the vast majority of all the other people that turn up at A&E currently would go to an urgent care centre. We've always been clear in this programme that we wanted to make sure that we ended up with the right care in the right place for patients. We have an underlying principle that home is normal and as close to home is normal. So we are currently carrying out work around how care in communities will be delivered. That's ongoing and will continue over the next few months. Clearly that then impacts on the number of beds that you would need in the acute sector and the types of services that are delivered in the acute sector. We will be continuing to refine this both over the next few months but also over the next few years. The two CCGs have been working very closely with the ambulance service over a number of years to try and make sure that only those patients that really need to go to hospital get transported to hospital by ambulance. Now actually, if you looked at the current figures, roughly 40% of call-outs to the ambulance service result in someone being transported to hospital. But even of that 50%, roughly 50% alone stay in hospital, the others are discharged. So we think there is still significant work we can do with the ambulance service and crews to look at how do we make sure that where it is safe, that patients are treated at home rather than being transported to hospital. The workforce is really important because we know that with fragmented services spread over two sites, it's incredibly difficult to recruit staff. So if I give you a specific example around accident and emergency consultants for a second. Currently the Trust has 5 emergency consultants. They work a 1 in 4 rota, which means they're on call 1 in 4 nights, 1 in 4 weekends. If you looked at some of our surrounding hospitals, so for example Stoke, where the consultants are working a 1 in 18 rota, if you were a newly qualified emergency consultant, where are you likely to put an application in for? Is it somewhere where there's a big consultant body to provide you plenty of support and mentoring to enable you to start your career well, where you're going to be on call maybe once every 18 nights and maybe once or twice a month at most? Or would you want to go somewhere where you're going to be on call at least once a week? I don't think it is beyond the realms of possibility to work out that somebody who's newly qualified would probably want to work in a department where there is more support from senior colleagues and where the on-call is less onerous. But equally that's the same across a lot of other disciplines as well, including nursing and including therapists. It's much easier to recruit where you've got large teams that can provide the right support for people, for staff, rather than smaller departments where staff feel isolated. No, I think this presents real opportunities for our staff. I mean, I suppose the fundamental message for me for staff is, if this was your mum or your dad or your brother or your sister, do you think that the way we currently deliver services is the right way to deliver services? And if you don't, then actually what we're doing is the right thing by trying to make it so that patients get the right care in the right place at the right time. And I fundamentally believe that. But this is going to create new opportunities for staff to work in different ways, not just in the acute sector, but also around community and primary care. We want to deliver more services out of hospital. All of the evidence is that hospitals aren't great places to be unless somebody is very ill and needs to be in hospital. The right place for somebody to be is at home or as close to home as possible. It gives unique opportunities for us to change the way we deliver services, and therefore unique opportunities for staff to work in different ways. The consultation process is a rigorous, comprehensive consultation. My personal view is I would like to see as many responses as possible, both from our stakeholder partners, other interested organisations, as well as individual members of the public. It is quite clear that we need to take into account the views of any responses we receive before the two CCGs make a final decision in the summer.